Yeah, I think that one of the major development in recent years is haploidentical transplant, especially with post-transplant cyclophosphamide that knock down the alloreactive T cells and upregulate T regulatory cells. And the biology of haploidentical transplant is really different. So although the cytogenetic markers are important and the number of induction therapy, there is, for instance, a dissociation between the graft versus leukemia effects and graft versus host disease in the haploidentical transplant, and there is no lower relapse rate in patients that have acute or chronic GvHD. And so there is, today we have shown that the donor, we can fine-tune the donor to the patient. It's different if the strategy is with PTCy and or with ATG. There are some HLA, new HLA factors that are important, like matching in HLA B1 leader and mismatching in the HLA DP mismatching. And we know that we can give post-haploidentical transplant agents against the leukemia. We can also play with the conditioning, so it depends on the age of the patient and the activeness of the leukemia. We can fine-tune the conditioning between myeloablative to reduce intensity and non-myeloablative conditioning, depend of the age of the patient. We can also add ATG to the PTCy in order to reduce chronic GvHD, and we can also reduce the PTCy in order to reduce the toxicity, like the cardiotoxicity. So I discussed today many of the new development in haploidentical transplant, and I think that this offers a donor to all our patients, and we need to improve the result in patients with active AML and also in elderly patients with our frail patients.